Right, I think we can get started. Welcome everyone. I'm Romany Sutherland and I'll be your host this evening. I am so excited to have so many people join us at such a short notice. I apologize for the short notice. And on behalf of the Western Cape branch of SAMLA, as well as Genoa Underwriting Management, who's assisted us here and partnered with us, welcome to this. And we're very, very excited to introduce you to our lineup of great speakers and who are obviously giving up their time in these terrific circumstances. So thank you very much. And how this all started was I received a call from an anesthetist, and she said to me, you know, the COVID hasn't really hit them yet, but she's already having sleepless nights with regards to with regards to how they're going to triage patients when they come into her unit. She is one of the anesthetists that is going to be running her team in the ICU. And she said to me, are there any legal guidelines? I said, well, you know, there aren't any legal guidelines, and it's very tricky gray area there because, you know, we can't say one life is to be put ahead of another life, but from a medical and clinical point of view, obviously that is not the case. And then the team, the SAMLA team and I, we sat and we chatted about this. And that's when Elise Burns-Hoffman mentioned that she'd been in touch with the Knott Foundation and told us a little bit about Professor Knott and John Barden and what they were doing. And we thought, my goodness, it would be so absolutely wonderful if we could get them both in to come and sort of help us answer this question. Now we have our doctors, as well as it's actually all the people that are working in the hospitals, down to the laundry, as well as the you know, the porters even. They are all sort of have this heightened stress at the moment and pressure. And you know, we're already dealing with scarce resources in terms of equipment, as well as staff shortages. You know, that's a normal day in South Africa. And now you have this novel virus that comes in. And even though we are sort of behind the drag curve in terms of, you know, knowledge and dealing with this virus, we are still sitting, you know, with not knowing exactly how this works, what sort of treatment works best. I mean, from day to day, the doctors are telling me things are changing. And I've you know, knowledge cancels fear. And if you don't have sort of knowledge of how to treat your patients, you can imagine that stress level increases exponentially as well. Now, in what we did is I spoke to MJ Demant from Genoa, and I said to them, listen, MJ, you have this great seminar that you are hosting for over 400 doctors. Please, can I give you this poll to run, this poll for the doctors to answer, just kind of checking in and seeing how they are doing. And it was actually fantastic. We got 307 doctors to complete the poll, and we got some really, really good information. I don't know if you saw, just whilst you're waiting to get let in, you saw those slides, but there are some really interesting figures. We can see that the docs are definitely battling. They're feeling unprepared. They also, you know, think that, well, mentoring, having a mentor perhaps would assist them greatly. And so there's various information and data that we can put up in due course, perhaps towards the end of this webinar, just so that I don't take too much time from our speakers. But we've got this information, and we're going to be looking into mentoring to ask the retired doctors, specifically pulmonologists, physicians, radiologists, to come on board, set up a WhatsApp group or an app for the doctors, so that if you're a general practitioner and you haven't done any ICU work for a hell of a long time, you know, you can have that resource available just to to phone up the pulmonologist or physician and say, listen, I'm unsure what I'm doing here. Can you please help? So that's one thing we're going to explore. And I know these are difficult times, and under these circumstances, the normal rules, I guess, are don't sit. And we're going to be exploring. Norton Rose Fulbright is going to be exploring legal liability in these times and what to expect in due course in the next couple of years as to what we're going to be looking at. So that will be done towards the first week of August. We're going to be looking at that. And then very exciting, we've got some international and domestic speakers that are going to be speaking on the 16th of July. And we're going to be sort of interrogating the mental health a little bit more and investigating as to how the docs and the nurses are doing. And we're going to be speaking to a nurse who has actually needed to be treated in her own ward. So that's very exciting. And so what we're looking for here is, and what comes through on the poll was that everyone just needs, what will assist them with their stress levels is needing information, as well as getting some emotional support, and then also knowing that they're doing a good job. And so I am so very excited to hear our great speakers that are going to present to you. And I'd like to ask Elise Burns-Hoffman as she will introduce Professor Knott and John Bodden.
Thanks, Romany. There's a lot of information about both Dr. Knott and Jonathan Bodden that I have managed to collect in my research, and I can't go through all of it, but I am going to read a couple of things. But as an introduction to how I met, I've met John before, and tonight's the first time I'm now meeting Dr. Knott. I armed myself with this amazing book called The War Doctor when we got our first lockdown here in South Africa, and I couldn't put it down. And I was so inspired by David Knott's story and the stories he tells in his book that I had to make contact with the David Knott Foundation, which led to John and I having I think we probably scheduled half an hour, but we spoke for probably 1.5 to 2 hours about all sorts of aspects of the David Knott Foundation. But as an introduction, Dr. Knott is a Welsh consultant surgeon. He works mainly in London. And is as a general and vascular surgeon, but he also volunteers in disaster and war zones all over the world. He's been honored for his work, as has John, and I gather is called the Indiana Jones of surgery, is one of his nicknames. I picked that up on the net, so it must be true. As a vascular surgeon, he specializes in keyhole techniques, especially for repairs of abdominal aortic aneurysms and distal arterial bypasses. And in 1999, he was the first surgeon in the world to perform a femoral popliteal bypass using, I really battle with this word, laparoscopic techniques. And then in 1993, Dr. Knott started working in disaster and war zones all over the world, and it's included places like Afghanistan, Bosnia, Chad, Darfur, Gaza, Haiti, Iraq, Libya, Sierra Leone, and opposition-held areas of Syria. You have to get his book to read all the stories, but they are just absolutely incredible how he has worked in these very, very difficult circumstances with almost no facilities at times, with bombs going off and going through into operating theaters and so on. I mean, it's really quite incredible. But whilst he was working in these environments, he started actually training his colleagues in trauma medicine. And so was born the idea of trauma training. Dr. Knott can fill you in on the details of that, and led to the David Knott Foundation, which he and his wife started in 2015. And they Dr. Knott takes these courses all over the world to war-torn areas to help surgeons and doctors and nurses and deal with trauma medicine. If I've got anything wrong, please forgive me, but that's my summary. And then introducing John Bodden, because I'm going to do it all at the same time. He's also been very much honoured by the British Empire with an award, and he joined the foundation in end of 2019. And his big job as an operations director is taking these courses all over the world and making sure that they run smoothly and safely, which I'm sure they do, given that his background is 25 years in the humanitarian sector, working with the different humanitarian operations team, working in places like Afghanistan, Sudan, Sri Lanka, Bangladesh, leading disaster management processes in Haiti, the Philippines, Nepal, Bosnia, Mozambique. And he's also spent six years building and managing the United Kingdom's government emergency medical team. And I found a clip here, John, that you can tell us about some more, is that in one of the bits of research, is that in Kathmandu, there was a hospital that had 10 operating theatres and 700 beds, which had been so devastated by the earthquake that it was down to one emergency operating theatre and a basement car park. But in 6 days, you had back up to 10 operating theatres and 400 beds. And you did 200 hours of work and travel in Nepal in a 10-day period, which is just, I did the maths. I actually didn't believe the calculation. It's just absolutely, I don't even know how you stayed alive in that time, but apparently your superhero power is indefatigability, which I think we could all do with a bit of. If you could give us the recipe, please. Anyway, I welcome you both, and I'll hand over to you. Thank you so much for your time.
David, oh, you're on mute.
Do you want to go ahead?
No, you go ahead, David.
All right. Well, hello everybody, and thank you very much for that very warm introduction. Yes, it's been a very strange time for us, I'll be really honest with you. Usually with our foundation, we run courses, and in fact, John and I were in northern Yemen in January, where we ran a course to train lots of al-Houthi rebel surgeons. We go everywhere. We go to the government side, and we go to all over to train doctors, and we have a lot of equipment that comes with it. This has been going on now for several years, but the reason why I wanted to set up a foundation for training was because I think we're all very specialized in our ways, and although I'm a vascular surgeon at home, if you go to a war zone or you go anywhere, and I'm sure many of you are working in sort of similar environments, you have to be able to change your head completely and become a neurosurgeon, a facial-maxillary surgeon, a thoracic surgeon, an abdominal surgeon, an orthopedic surgeon, and also dealing with children most of the time. When I was in Syria, in Aleppo, in 2013 and 14 and 16, many of the cases that we saw were children. And so you have to be very adept at dealing with pediatric surgical emergencies and knowing how to resuscitate children. We had around 60–70% of all our cases at one stage were blast injuries with children, and it was a real, very difficult environment to work in. And following on from, and then of course, always in the middle of all this, you get somebody coming in with obstructed labor, so you need to know how to do a cesarean section. Elise was very nice in mentioning my book. I was cajoled into writing this book, which I didn't really want to, because I felt it was my own personal memories, but an agent would not stop knocking on my door, and finally I wrote this book, which came out last year, and it sort of exemplifies everything to do with my life, really, about how it was. But I think one of the most wonderful things that we've done is created the foundation, and it's got my name associated with it. But it's a foundation whereby we wanted to create almost for those people that have great difficulty in accessing education and accessing what's going on in the world. We wanted to reach out to those sort of people. We wanted to reach out to people on the front line. We wanted to reach out to people in disaster areas. We wanted to reach out to them, mainly to tell them that you have not been forgotten. We are here to come and help you. And it's sometimes that is the most important thing. Although sometimes we arrive in the back of Beyond with all our kit and try and put on the best show we possibly can, it's actually more important for them to realise that people do care about them, and that we are there to help. And I think the good thing about it is that John and I have been working in this environment for close on 30 years, both of us, and we have a huge amount of understanding of what it's like to be in very difficult places. I think that the other thing that we do as well is that because of COVID, which started in the UK, and we unfortunately have the worst mortality rates in the whole of Europe now for many, many reasons, which I can go into if you want. But we do have a huge amount of deaths. And I think that I've forgotten my train of thought for a second, because John smiled when I said that, and I looked at him and I've forgotten my train of thought. But we do have a lot of problems, and in fact I've got it back again. And with our foundation, I did some work with one of the International Rescue Committee, and they did some modelling which they promulgated to the world to suggest that this virus, and we heard from WHO yesterday, is really not going away and is really ramping up around the world. And to the extent that, there could be 3 million people, 3 million deaths around the world shortly with the modelling. So it's a real problem, and it's getting, we're almost, feel in the UK that things are better. But I think globally, we're probably just at the beginning of what could be the worst pandemic ever. So with all this information and knowledge that I had, I decided, in fact, I met the Prime Minister at a Welsh meeting in Downing Street on the 3rd of March. And it's surprising that there was no real, nobody was particularly scared about this. We all thought it was like an influenza virus. And that's what the British government did. They thought it was an influenza, and they went on to herd immunity and so on and so forth. And it wasn't until the middle of March that we went into lockdown. And by that time, it was probably too late for us, because we are a huge hub. We have Heathrow Airport, which is one of the busiest airports in the world, and nothing was stopped. We had people coming in from all over the world and infecting everybody in the UK. And so that, I think, was one of the reasons. And in fact, one of the editors of The Lancet who I got in touch with, because when we worked the modelling and we worked out that there was going to be a real pandemic, then I wanted to sort of tell the world about it. And I wrote this article in The Lancet to say that, refugee camps and war-torn areas, and also places of very high density, are really going to be in trouble if we don't do something about it soon. And one of the papers that the editor of The Lancet came back to me and said, David, did you read the Lancet paper on the 30th of January 2020? And it basically said that if you do not do something immediately and go into lockdown immediately and close your airport, stop people from coming in, then this will become a really terrible pandemic. And so about the middle of March, I still didn't quite realize what was happening. And the lockdown happened. I went to the hospital and suddenly was told by the managers there that, David, you're going to hang your coat up and you're going to have to retrain as an intensivist, because we don't have enough intensivists. So the first thing I did was I bought this book, which was, I don't know if you can see it, which is fantastic. It tells you everything about ventilators. It tells you everything about how to deal with positive pressure ventilation, how to deal with everything to do with CPAP, the whole works. And I read that. It's a book which contains 1,000 pages, but I read it in about 3 days, and I felt equipped really to wander, but I wasn't equipped at all to discover what I was going to find. Our hospital, which was has about 700 beds, suddenly we had 600 patients with COVID, which came in a very short period of time. All our intensive beds were full of COVID. We discharged everybody that could be discharged. And we ended up having a catastrophic time with getting the correct amount of protective equipment. And not only that, I was being asked by that time via various intensivists around London, David, because you've got so much experience dealing with disaster zones, would you make a video, because we're not able to cope. And so I made a short video to explain to people that, you know, this is a real something that you'll never experience before. You're going to have to triage people into actually making decisions on who gets treatment and who doesn't get treatment, because we had what we did, which was a wrong thing to do. We turfed all the old people out and we put them into old people's homes to make space for our you know, COVID patients. But nobody quite realized that the old people were the ones that were going to suffer the most from it all, really. And it is true that the mortality rate from people who were obese, that were people over the age of 70, was absolutely enormous. And in fact, the results that we had from our intensive care unit was such that if people on an intensive care unit on a ventilator, we had, with the best hands in the world, the best first world technology, 65% of those patients died, unfortunately, on the ventilator. But if they had another regional problem, for example, a kidney problem as well, on top of their lung problem, then they went up to 85%. So it is an enormous death rate on ventilators. And to actually then not be able to talk to relatives, not be able to discuss the problems with them because we couldn't, it was over the phone. And for people to just then, people on that couldn't breathe very well, that were on CPAP, who are going to go onto ventilators, for them to have their last discussions with their family saying, you know, well, you know, I may never talk to you again, was really heartbreaking for all the people that dealt with it, for all the staff, for all the nursing care, nurses and doctors. And it was a real, really dreadful time. We're sort of much better now. We've got to the stage whereby intensive care unit is not as full. We still have some beds. A lot of our patients died on the intensive care, and that was really hard to deal with as well. And I found it really difficult. I reverted back to what I felt at the time when I used to come back from war zones. You know, I came back sometimes. I sent my wife and children off somewhere because I didn't want to come back and give them COVID. And I had a suspicion, you know, that, well, I may get it too, but we had wonderful PPE, and I, unfortunately, and luckily I didn't get it at all. But lots of people did get it, and lots of people were off with it, and so on. But the stress that I certainly had, and the stress that you know, a lot of us went through, was very, very significant. And I think I've had about 20 minutes, so I'll stop now and then pass over to John, if I may.
Thanks, David, and thanks, Elise, for that. Yeah, very kind welcome. It was true in Nepal. I'd forgotten about that. It does sound quite good when you put it like that. But the superpower nonsense was the Evening Standard. That was had nothing to do with that. So yeah, I mean, thanks everybody for coming to listen. And I guess just to add to what qualifies me to be hopefully to be speaking here is that I've 15 years or so I spent working in those war zones that Elise mentioned, Afghanistan, Sudan, Sri Lanka. The post-traumatic stress disorder that I picked up by not looking after my mental health in the early years of the Wild West in Afghanistan. And then the work I did for the UK Department for International Development during the West Africa Ebola crisis. And so on the latter, I was responsible for recruiting, training, deploying, and getting home safely all the NHS staff that we sent to Sierra Leone. So, you know, amazingly, given that this was, we were going to ask people to go into what was called the red zones, i.e. direct treatment of Ebola patients. We had 1,600 volunteers, which is absolutely amazing. And that always, the courage of our frontline medics has always amazed me. I found it with the UK emergency medical team as well. In the end, we sent 250 or just over 250 there, and they all returned home safely. Thanks very much. But early on, the Department of Health and NHS England were very aggressive in their sort of, they call them requests for what was I going to do to make sure that their staff were safe. And they were mostly talking about their physical health and what could we put in place. And of course, there was huge amounts of procedures of donning and doffing and everything else to keep them safe. There were 24/7 hotlines for people who were worried that their procedures were not good enough in their hospitals they were sent to, and so on and so forth. That was that. But I knew from experience that their mental health was going to be equally at risk with this, because they're going to be in a foreign country fighting a really deadly disease with, about 2-3 millimeters of protection between them and just this absolutely deadly disease. They're away from their family, and for me, them very importantly, which there's some similarity here with COVID for sure that David's just mentioned, but back then, I don't know, not being medical, how many people one expects to lose on a ward in a given week, but here they were going to lose between 50 and 80% of their patients and 100% of the children under 5, which is just, that there's prolonged periods of extreme stress with very little respite and relatively few positive patient outcomes that they can celebrate in order to ameliorate some of the stress, which is for me a sort of recipe for mental health disaster unless you handle it properly. So there were things in place during the deployment, but I asked one of our best mental health trusts, what they suggested and what could they put in place. So during the deployment, and then for a year afterwards, there was therapy, I guess, available, counselling if you wanted it. It started off with telephone or Skype, and then if they both agreed, then it went on to face-to-face therapy if wanted it. This was obviously extremely confidential. It was outside of their workplace, and it was not mentioned at all to their trust or their line management, and there was very, very little take-up. It was surprisingly little, which was a bit of a shock. But I think that's down to the stigma that there was and still is about health-seeking behaviour when it comes to mental health. So for any team that's putting itself in harm's way needs some sort of provision for their mental health, almost whether they like it or not. If you want to put in place something that's going to be successful, it's got to be appropriate sort of personally and culturally to the people you're trying to help. And there's a couple of quotes, if I may, from the feedback from the people who did take up the Ebola service that we provided. And one of them said, "The period of coming home was the most traumatic for me. It was really hard. It took me a full month to really feel happy to be back home again. And that was a little bit of a surprise to me." And another who said, she, meaning the therapist, was the only person that I'd speak to. It's funny, I spoke to her about work and what was happening and what I was struggling with and whatever. And I didn't do that with my family and with my husband. I just spoke to her about it, and it was great. So those two quotes tell me a bit that, it's having to relate to people maybe at home or friends when you've been through something traumatic is just not always that easy. Perhaps you don't want to burden a loved one with your troubles. Perhaps you've tried to do that and their frame of reference is so outside of what you've been through that they just can't understand. Or perhaps like me back in Afghanistan, you wouldn't ever ask for help because that was a sign of weakness. So you just got on with things. Then a little example for me about the culture. So the episode in Afghanistan that led to me initially having PTSD, I guess. So myself and the 3 Afghans I was with offered a visit to a psychiatrist, which I did. It wasn't much good. She'd never heard of post-traumatic stress disorder, so just had a chat. That was nice. But the main point is the Afghans just absolutely, Mr. John, we have friends. What do we need psychiatrists for? And anyway, someone might see us. So that was just culturally completely inappropriate. So that help was offered, but it wasn't really offered because no thought had gone into what form that help took. So you've got to make sure that that provision is culturally and personally appropriate. I think it's got to be accessible outside of work, but if you can, if you can make it overcome the stigma, there's no reason why it can't be in the workplace as well. I think there's some evidence that some people like talking to their peers, and that receiving psychological first aid from peers is the best way forward, because they know that the person they're talking to has gone through the same thing as they have. So there's a frame of reference, as I said. There's evidence of this from the Norwegian military when they were fighting as part of the coalition in Afghanistan. So they found that people coming home to Norway and straight to the airport where their family a big banner and welcome home daddy and all this, when 24 hours later they may have seen their friend just shot, was too much to handle. So they hit, and what they saw was a real huge spike in domestic violence towards the mostly female spouses of the servicemen. So they hit on the idea of making the tour 2 weeks longer, but making those last 2 weeks at a military base that they weren't allowed off in Norway, where they could all depressurize, talk to their peers, of course have medical and psych teams ready if necessary, but basically just that depressurization. And I think they found that domestic violence went down lower, in fact, after that, because somehow they just had that chance to depressurize with their peers, with people that have gone through it. But as my second quote was, sometimes you want to talk to someone who's outside of it a bit, and maybe just you feel you trust because they're professional. I mean, I know that helped me eventually. But yeah, so I think being outside of that experience, as I mentioned earlier, I think another really important facet of getting a psychological first aid program in place that works for people is that management are trained in the need for it and in how to achieve it. And that's probably the best way, rather than coming in and going, boom, this program is great, we do it this way. If you get the buy-in from whatever management structure you have, who should, if they're doing their job, know that work culture and their individuals in it the best, then they will know what resources they have and what kind of program then is going to work best. But having said that, there are programs in the British Red Cross. It's called the Karma approach. There's WHO and Public Health England all have different approaches, and if anyone's interested, I can give Romany those, and she can distribute them afterwards. Or I have a good friend who's actually been asked to review the Public Health England and WHO guidelines for this, and has done so. She uses a focusing technique for psychological first aid, and she's pretty expert at tailoring those programs to fit properly and so therefore be useful. And she did that after the Nepal earthquake and is now doing it safe for COVID. And link me to her. I think because, I don't know. I think they should be mandatory almost. I mean, I really do. That if you're in a high stress, rapidly changing, highly uncertain situation, I think some sort of psychological first aid, or at least that there are members of the team who can spot the signs and know when a quick session in the cupboard, if that's where it is, or wherever it might be, just to say, well, is everything okay? I think it's
environment crash.
And sorry. That's where was I? Right, because I think it should be mandatory because I'm a convert. That's why I was really skeptical about it. I mean, seeing that psychiatrist in a few days after, what happened to me, just very briefly, was I sat with a Kalashnikov on my head for about 4 hours, thinking I was going to die. So obviously that's pretty stressful. It's long-term stress, which again, similarities. It's very high adrenaline levels for that length of time, which I think it can also be on the wards when you're just struggling to get things done with the low resources. But I was skeptic, and it took me there for over 10 years to seek some sort of help with PTSD, and I realized that those 10 years I had been putting myself in more and more dangerous situations, self-medicating with alcohol and parties to get through, and messing up most of the important relationships in my life. So I think that, you know, I'm lucky to have survived that decade in some respects when I look back. And the sorts of behavior I displayed are really not the kinds of behavior we need in our frontline medics. Hey, you know, you need people to be thinking clearly, to be looking after themselves, to be happy, and then doing what they do best, not just taking bad decisions and things. So, well, I don't regret very much in my life. I think it's been great, but I do regret that I didn't seek help earlier or know that help was available. So I think if it's at all in your remit to provide help for your staff, or for you personally to seek some help if you want it, or to pressurize your management into making sure that that's there for you, then if only as a precautionary measure, please do it, because I think it'll hopefully save you a lot of grief in the future, professionally and personally. As from my experience can say that it will. So thanks for listening.
Thank you very much, Dr. Knott and Jonathan. There's a chat box, Romney, I think you already said, but please, we'll deal with questions later, because Prof. Deed is going to speak next. But we can deal with the questions at the end, right?
Yes. Yes. Prof. Knott and Jonathan, thank you so much for that. You know, it's fascinating, and it's amazing. The one thing that COVID, this virus has taught us is, you know, we're all in the same boat. Doesn't matter where you are in the world, and I think that's become, you know, so absolutely apparent. I mean, we're speaking now on this on Zoom, and it's easy to do this as a result of this having happened. And you know, same goes for us learning from each other. And thank you. You know, I know our doctors and nurses and medical practitioners can learn from your experiences. And Jonathan, you know, with regards to mental health, I was so 100% behind you in that respect. SAMLA has you know, done quite a few seminars on mental health, specifically looking after the doctors. And you know, we all get our cars checked up and put it in for a service before we go on a long trip. And in order to keep them running well, we go and get them serviced. So at you know, at certain times. So let's keep. If you want to be a high functioning human being, you need to put that sort of, you know, do that sort of work as well, and go and make sure that you can still cope with that. And I know, you know, with regards to triaging patients, I know that sort of to minimize the moral distress, you have sort of rules that, you know, the triage team will not be the clinical treating team, for example, and you know, little things like that are of assistance that we can also learn from each other. And I know and Elise, you just said we're going to ask questions just now, but if I may just ask one question before we go to Prof. Dida, is there anything you do in terms of a team, as being a team leader, when you go to one of your, you know, these high pressured areas, what do you say to your team that you are going to be working with? Is there anything you do in order to prepare them, you know, for what is coming, firstly, and secondly, in how to sort of I don't know, realize in the moment what is happening and kind of, you know, process it in a way?
I take that question. So when I'm working in war zones and going to disaster areas and so on, or when I'm teaching or whatever, I volunteer to go. It's something inside that I volunteer. But in this circumstance, none of us volunteered for this. We have just got to do it. And that's the difference in what's actually happened, is that it's, you know, none of us volunteered to go and work with COVID and see what the disaster will unfold for some patients and some families and everything else. So it's a very, very difficult environment. And just to exemplify what John was saying, really, I mean, the way that I think that we coped we had young nurses, we've got all the cleaning staff, the portering staff, all these sort of people that were involved with us, and we all became a big family, to be honest with you. And in the mornings when the intensive care, we would meet in the morning, about 40 of us would meet in the morning, and we would discuss all the cases that we had overnight. We would discuss how the patients were. It was a very difficult decision to decide not to continue ventilating and so on, but we were all in it together. Everybody had a voice. Everybody could say something. It wasn't that the senior person there was in charge and everybody just had to listen to that senior person. It wasn't like that at all. Suddenly we all became this real band of brothers, and that was so important, because I now see people around the hospital who I dealt with and was working with 2-3 months ago, and we're really good friends. I never met that person before, but the knowledge that we were all full in PPE and I could tell who it was, and when we went to the coffee room, you know, I could see who it was. And now everybody is very much more friendly and much more understanding of each other than we were ever before. And it's a very nice thing to have felt. And I think that the knowledge that you have when you are working in these places is to say that, you know, it's not bad to cry. You know, it's not unheard. And if your colleague is not feeling very well that day and shouting at you, or, you know, it's don't worry, because he is suffering, he's got some stress. Give him some love. You know, that's what you need to do. Not not fight back. You've got to all be in this together, and it's something that's very difficult to really tell. So you can't read it out of a book. You have to really appreciate what it's like to be there. And I think if people are in the same environment, they really understand, and you really do. It's very difficult to go to an environment and explain to somebody who's, you know, playing a game on the internet and then talking to them about this. They won't understand. You will all have to be within it together to really understand what it's really like.
Thank you so much for that, Prof. And yeah, it's amazing. It's been, I guess, I love the way I speak like this, but I haven't been sort of in any of the, you know, the situation or the ICUs or the hospitals. But it just from hearing friends and colleagues speak about it, you know, it's, as you say, creating a just culture when everyone can sort of say what they feel and say what they're worried about. And I just love the way that you say, you know, you still all become friends, and that's just wonderful. Thank you so much. And Jonathan, thank you both very, very much. If I may introduce our next speaker, who is our own superhero here in Cape Town and the head of the COVID unit here at Critics Care, Professor Keerton Dida. He's a South African National Research Foundation A-rated clinician scientist, has a joint appointment at the University of Cape Town, and LSHTM. Prof, you'll have to please translate that. He is a hospital-based clinician, head of the Division of Pulmonology at the University of Cape Town, and immediate past president of the South African Thoracic Society. His research work has focused on respiratory pathogens, including TB. He has been the recipient of several prestigious awards, including the International Union Against Tuberculosis and Lung Disease Scientific Award and the 2018 European Union-funded EDCTP Scientific Leadership Award. He's been profiled in the Lancet and serves on several national and international academic and advisory bodies, and holds 6 patents related to diagnostics and vaccines. Prof, if you please proceed with your presentation and tell us what is happening on the ground now in Cape Town.
Okay. All right. Well, thanks for that kind introduction. I think it's a bit daunting and challenging to give you a sort of comprehensive overview of what we've been going through here in Cape Town in the last 3 months. So what I thought I'd do is go through some of the our sort of learning experiences and challenges. And much like I think David relayed, our journey began with a lot of uncertainty. I'm just having a problem advancing my slides here.
Hi, Prof.
Yeah,
Managing.
can you? Yeah, well, I'm not. Well, I think it's back online,
Yes.
right? So, yeah, so our journey really began with uncertainty, as David outlined in the beginning. Certainly, speaking to myself, to be honest, and like many colleagues, I envisaged a short journey. I really thought when our first cases were described in early March, and at that stage, I thought we would have a very low disease burden with a short time to peak. Given that we have a fairly young population, and for various other reasons that I won't go into now, and seeing that there was a short time to peak in several other countries, including some southern European countries like Greece, and I thought, well, how bad could this get? And at that stage, we only had a handful of patients in the hospital. We had a small COVID ward, initially only about 4 or 5 patients, and this was within the Department of Medicine led by the infectious diseases team. And fast forward to a couple of days ago, and we now have almost 138,000 cases in the country. And although it's well documented, I'm not sure how widely appreciated it is within South Africa that we are now, in terms of burden of disease, in the top 20 countries in the world. Although that's an underestimate given the very limited testing capacity we have. And the Western Cape province, as you can see on this map, is really the epicenter of the epidemic, with over 60,000 cases described. This is the hospital that I'm based at, Groote Hospital. It has just under 1,000 beds and several ICUs, both medical and surgical. And at this particular juncture, the capacity has now increased to about 1,200 beds. We currently have about 280 COVID-19 admissions, about 8 COVID wards, and our in-hospital mortality is now close to 25%. Another dimension to this is, and I think David and Jonathan alluded to this, healthcare workers and PPE. We've had almost 3,300 healthcare workers diagnosed with COVID-19 in the Western Cape province, and this is just in the public sector. We probably could easily double this number if you included the private sector. There's been about 280 admissions and about 25 deaths. In this slide, you can see, courtesy of Dr. Mary Ann Davies, some of the risk factors associated with death. And on an attributable risk level, diabetes, hypertension, and chronic renal disease account for about 75% of the mortality risk. And in our setting, HIV, active TB, and previous TB account for about almost 20% of the attributable risk of death. And just taking it down to a sort of more granular patient level, just to give you a feel, I'll just briefly run through one of the typical cases that I saw very recently. This was an 83-year-old man who had high inflammatory markers, worsening oxygen or increasing oxygen requirements. And you can see the X-ray on the right-hand side, or the right bottom panel, typical appearance. And some of the things that we do in clinical practice includes proning. This patient received some steroids and anticoagulation. We're not clear on whether this intervention works, but in this particular case, this particular patient got anti-IL-6. And is in a stable but critical condition. There was consensus here after discussion that this was not someone who was going to receive mechanical ventilation. And this just gives you some feel for the complexity. So I thought I'll just run through some of the medical challenges and learning points that we've sort of learned over the last 2 or 3 months. And some of these points have been alluded to already. Selecting patients for mechanical ventilation, given the limited bed capacity, is a challenge. And there's 2 parts to this. The first is timing, and the second is triaging. So from a timing point of view, it can be quite challenging looking after these patients in the high care or in the ward. They often run oxygen saturations, in the from anything from 75 to 85%. Yet they can be quite comfortable scrolling through the internet on their phones, the so-called happy hypoxic. And it can be quite difficult to make a decision when these patients should actually proceed to intubation and mechanical ventilation. I won't go through the details about that. Triaging is another issue. We use a triaging tool. I've listed some of the parameters on this slide. And basically this converges into a priority score, which we can then use to decide on whether somebody gets mechanically ventilated. It's not the be and end all, but it's a guide we use. Transporting these patients to tertiary centers from outlying hospitals can be quite challenging when oxygen requirements are high. One of the innovations we have, certainly at our hospital, is an intubation team. It's a group of 3 or 4, usually anesthetists, that have more high-level personal protective equipment like N99 masks, and who are very experienced in coming in to intubate patients and transport them to the ICU. Another sort of challenge we face on the ground is the diagnostic one. The test, the RT-PCR test, has a false negative rate of about 20 to 30%. And often we manage patients empirically where they have a typical picture of COVID-19, and sometimes 2 or even 3 tests are negative, and we do a tracheal aspirate, for example, in the ICU, which would then test COVID positive, and we can chat more about that later. There's also a very high mortality in the ICU, and I think David alluded to this already. Many of our patients present with very advanced disease. They present late. They have very poorly controlled risk factors. From a socioeconomic point of view, there's a number of risk factors for poor respiratory health, including previous TB, smoking, exposure to biomass fuels. And so our mortality, certainly in the tertiary center, is closer to 80 to 85% in mechanically ventilated patients. One of the interventions that's life-saving is high-flow nasal oxygen. And you can see a picture of it here. And given the limited ICU beds, this has certainly been a life-saving intervention in many patients, with about anything from 40 to 60% of these patients having a good outcome and avoiding need for mechanical ventilation. Supply of these units is a major problem. As I said, the epicenter of the epidemic is now in the Western Cape. But we have cases now ramping up in other provinces in the country. There's now a huge demand for these high-flow nasal oxygen units, and they're in very short supply globally. There's a waiting time of several weeks for these units. There's also the other challenge that, unanticipated challenge certainly, that we came across was a severe strain on the hospital-wide oxygen supply. This has been described also in a few hospitals in the UK. And we're using a very high volume of oxygen in our hospital, and with an unprecedented number of high care beds and ICU beds, almost 70 now running on very high oxygen demand. And in addition, the conventional oxygen usage and the oxygen usage we have in the wards, there are times when certainly one gets the feeling that one doesn't get the same effect when using supportive measures like high flow oxygen, high flow nasal oxygen, and some of the hospitals are really operating on the brink of running out of oxygen. Supply, fortunately, is not a problem. We have regular oxygen delivery, but it certainly there's a limited capacity in the hospital at the rate at which you can supply oxygen. We also, as has already been outlined, this is a completely new disease. It's a rapidly changing landscape. There's information overload. I think I looked at PubMed today, and there was something like 28,000 articles already in the last few months on COVID-19. It's also difficult to know what to do, the optimal therapy that one needs to use, optimal doses. Typical example is steroids. Many of you probably heard of the recovery trial and the mortality benefit of steroids. But until recently, the practice, certainly in South Africa, has been very heterogeneous. Most of us thought steroids would be unhelpful and likely harmful given the harm signals from other viral illnesses like influenza and the other coronaviruses that we encountered several years ago. Then all this changed completely with the publication of the recovery trial, and now we're using steroids in almost everyone who needs oxygen. And that just shows the value of having controlled trials. There's also hydroxychloroquine, which many of you have heard about, and certainly now shown to have no place, at least on its own, for the management of COVID-19, both in severe disease and even in early disease in ambulatory patients. And this showed the danger of speculative medicine, and again, the need for controlled trials, and the negative trials are also important. We have, through Tygerberg Hospital, the pulmonology group there has developed a WhatsApp sort of messaging group where somebody looks at the literature on a weekly or twice weekly basis and gives us regular updates. There are also various other online tools that one can access, because the real challenge keeping up with the changes in the literature and new information coming out every day, and trying to distill all this information into something that's clinically useful as a busy doctor or a clinician. We've experienced major challenges with expanding our services, and the main problem has really been nursing support. So whilst we've had beds and ventilators, getting enough nurses or nursing staff to run these beds has been a real challenge. There's also major challenges with coordinating hospital-wide response across various disciplines. We have a multidisciplinary rota now in our COVID wards. We have specialists and doctors from all specialities that are now working in the COVID wards. PPE is a major issue, and it's a global shortage, and we're experiencing that here as well. The one aspect that has already been mentioned, and I think David mentioned this, is the diversion of resources to COVID, and that has really marginalized the care of many patients with non-COVID conditions, certainly in the pulmonary service. Besides lung cancer and obstructive airways disease, the major problem we see in this country is one of TB. And just to give you some economies of scale, there are lots of different predictive models, but many of them have suggested that we're going to experience total mortality burden of roughly about 50,000 cases over a 12 to 24 month period. In contradistinction, TB kills almost 60,000 people every year in this country, and that's sustained on a year-by-year basis. There's been a sharp decline in the number of patients being tested for TB and the number of patients started on TB treatment. And on a global level, so this is not a problem only in South Africa, it's a problem in many countries in the world where TB is a problem. And it is estimated that over the next 12 to 24 months, there's going to be about 200,000 excess deaths globally due to TB because of this. So that's just something to bear in mind, that this is a major challenge. David and Jonathan already spoke a lot to this point about mental stress, fear, depression, and guilt amongst healthcare workers for all sorts of reasons, anxiety about falling ill, and it's not only anxiety, it's a real problem. We have, I mentioned the very high rate of disease in healthcare workers, and this takes its toll. At any one point in time, there may be large numbers of people, members of the team, who fall ill. It's quite a heavy workload, especially with the on-call commitments. I gave you a feel for how complex these patients are, and in the COVID wards, certainly in the high care wards, we have 24-hour senior cover, and same in the ICUs. And this can be quite overwhelming, the workload requirement, both for junior doctors and consultants. I mentioned the poor outcomes in the ICU, which can be quite frustrating. And it's quite daunting when one has really no end in sight. It's almost like running a marathon and you don't have a finish line. And that's what it feels like right now. And I think just to end off there, this is my last slide. It's been a huge reality check for myself personally in terms of what I expected and what we're experiencing now. We have also learned a number of lessons. I think adaptability is important. Pacing oneself is important. The leadership, as already mentioned by David and Jonathan, is very challenging. There needs to be flattening of hierarchies, and as already outlined, we all need to be part of one team. But there's also new knowledge and skill sets that are created. And for me, the personal lessons have been honesty and transparency about ignorance. This has been a learning experience for all of us, even as a pulmonologist and someone experienced in dealing with critically ill patients. This has not really prepared me or many of my colleagues for what we're seeing now. Collaboration and patience extremely important. And I do echo the sentiment that we all need to hold hands together and really look out for one another. So I think I'll end there. I'm not going to go through this list, but just to acknowledge a whole bunch of people in the Department of Medicine here, including our head, Professor Ntuzi, and Greg Caligaro, who is one of the pulmonologists in my division, who spearheads the high flow nasal oxygen unit, and a whole bunch of other people, infectious diseases, and various people in hospital management. I'm not going to go through this list. And several of the agencies, including the UK MRC, who funds a lot of the research that we currently doing, and I didn't have time to tell you about that. We are conducting a large randomized controlled trial looking at the utility of nitazoxanide in ambulatory patients. And also, we also involved in some of the vaccine trials and other work, which I'm not going to talk about right now. So I thank you for your attention, and happy to take any questions in the next few minutes. Thank you.
Prof, thank you so much for that. It's just, firstly, it's a horror story. It's absolute horror story, but I just, thank goodness for people like you guys for doing what you're doing, and really, being on the front line and fighting our fight. And before we go to the questions, I see we've got 9 questions waiting. I'm just wondering, Dr. Knott and Jonathan, do you have any comments or questions, and vice versa for Prof. Dido?
I just want to say, Prof. Dido, what a wonderful lecturette you just gave. It really encompasses everything that we have been through, really. I think there's nothing I needed to add. You've got it all there. And, you know, I just wish you all the very best with all your team. I think it's very important as well that people don't run away from it. The other clinicians don't run away, because from a surgical point of view, the surgeons now, you know, probably have not a huge amount to do. And a lot of our surgeons just didn't come into work and self-isolated at home and whatever. But I think it's all hands on deck, really. And if people really want to get involved, I think people should get involved. It's all of us in it together. And I think, you know, I confronted a couple of intensivists who I was determined I wasn't going to be pushed away from it, because, you know, I wanted to be involved. I wanted to help people. That's what we're in medicine for. And I think that a lot of the, you know, the people that don't actually involve with anesthetics and intensive care and respiratory issues, you know, they somehow should be brought into the fold. And we had difficulty with that, without a doubt. We had a lot of difficulty with that. But anyway, thanks very much. It was a great talk.
Yeah, yes, thanks, Prof. I think what I'd like to say about that is that I really hope and employ anyone who has any power to learn from this, because I do see it as a, you know, in a way, a dress rehearsal for something that really kills. I mean, we didn't get a case of Ebola here eventually, other than the ones we brought back to treat. But there's a latent racism in this country that had cases been popping up, you know, before anything happened, we already had children being barred from school because one of their parents was from Sierra Leone. Didn't matter, they'd never been there for 20 years. They were from Sierra Leone, therefore their child was not able to. I mean, that's ridiculous. That can be countered by proper education about this, about what's happening. Is something I didn't feel. I mean, at the early days in the Ebola, I met Dr. Jenny Harris, who's sort of on our TV about 3 times a week at the moment, as our Deputy Chief Medical Officer. And she said, look, the first rule of public health that I learned was that if the public perceives something to be a problem, it's a public health problem. So I said, well, why aren't you doing more then to explain that, you know, it's not genetic, Ebola, it's not, and it's the same now. We don't get enough information. I think that the science of this disease, perhaps the medicine that goes around it, is, you know, I leave that to professionals, and it's the work that they're doing. But in terms of other preparations for this, you know, you only have to watch the Steven Soderbergh film Contagion. If you haven't ever seen it, watch it. It'll make you angry, and it'll make you want all our politicians to have been sat in a film theater for an hour 45 minutes and watch that film, because it's you know, this is a dress rehearsal for something that kills 50-60% of the people who get it. That people are, you know, we have people wandering around the streets, even in lockdown. We have people partying, 1,000 people getting together just after a couple of weeks because they got bored. Now imagine if going out and you know, you stood to pretty much catch it and die. Then we've got a massive problem. So it's really about seizing this, in a way, opportunity, and that's something from dealing with natural disasters and other things, is that you've got to try and look if is there any opportunity, and amongst this absolute train wreck and catastrophe, is there any opportunity that can give people hope that they can focus on, that we can go and say, yeah, right. And one of those things for me is, well, next time when we have an airborne disease that's killing huge numbers of everyone, and not just primarily older people or whatever it is, but just everyone, then we get it right, that we all have the PPE in the stores. We don't have to go buy it around. We've got it there. We can protect our healthcare workers. We've learned from what we're going through now. And one of the other things they can do is just play the board game Pandemic. It's a cooperative board game. You either win together or you lose together. And that's something really important. I heard something yesterday with the head of AstraZeneca, which was quite good to hear, was that he was sort of saying, in order to fight disease like this, the free market and competition, that's not going to work. We need to cooperate, all of us in big pharma, in government, everything. We need to cooperate so that we can, as rapidly as possible, whenever anything like this hits, get a vaccine, get people vaccinated, get back on track, only through cooperation.
That's so true. So true, Jonathan. Thank you. If we can just go to the question. Yes, sorry.
Yeah,
Rob.
so I just wanted to, if I can just chip in with a quick question for David. So David, the kind of mortality you described in the ICU is very much like we seeing here. Sort of our mortality is closer to 85% in our ICUs. Though in the recovery trial, the steroid trial, the mortality was in the placebo group was 41%. Though you seem to describe a little bit of a different experience in London, what do you think that's related to? Something to do with socioeconomic status, the type of patients, the early experience? Any comments on that? I was struck by that difference, and your experience seemed to be a lot more aligned with what we're seeing in our ICUs.
Yes, I think that the steroid trial came quite late actually in our it was probably about 3 weeks ago. Dexamethasone is the cure-all, which by that time we have over 43,000 deaths in this country, and a lot of the patients we didn't anticoagulate lots of patients at the beginning. I used to walk around and there used to be people with gangrene of their fingers and toes, and major thrombotic episodes occurring in their arteries and in their arms and legs and so on. We didn't anticoagulate. We came into this, I think, quite late as regards the treatment, working out what was the right treatment for it. And so the results that we had were particularly poor. But not only that, I think, as well, is that the triaging, we didn't triage properly enough at the beginning as well. And everybody that had, whatever age they were, whatever morbidity they had, they went on a ventilator until that's why we had the situation that we had to, suddenly we thought that we've got to develop Nightingale hospitals, because we feel that every hospital in this country is going to be full of COVID. Now we need a reception area whereby other patients can go to. So we built 5 or 6 hospitals that had massive 4,000 beds each to take over. And I think it was a matter of we didn't know what to do, and our triaging wasn't good enough, and our treatment wasn't good enough, and we learned as we went on, really. But we just tried to create as many beds as possible. So I think, I think one has to learn from the mistakes that we made. I think there's no doubt that dexamethasone is the right thing forward, and you've exemplified that in your talk. And also triaging. We got to a stage towards the end where even anybody over the age of 60 wasn't ventilated because the results were so poor. So there were funny cutoffs which came about. And I think it's important for you to look at all those results that certainly we in the Lancet have published to give your best bet for your patients.
Thank you. Cheers.
Thank you. Thanks, everyone. Just to get to a comment and a question here, there is a question from Tamsin Gaynor, or not a question, a comment. As a 5th year medical student, it is incredible to see your examples of openness and honesty. This is not something we see often in our field, and it is inspirational. Thank you. Then there was a question from Jackie Stewart. This is a question for David. Giving your comments about the challenge with patients on ventilators, what would be the most critical recommendation that you would give to South Africa? And a question there for Prof. Dieter. We have severe shortage of mental health professionals in South Africa. Possible to provide any methods to provide treatment online?
Well, I think I answered the question that Prof. Dieter, that question was sort of answered really. I think what South Africa has to do is to really hone down on what is good and what is not good in this virus, and really look at all the research that's come out, learn from mistakes that other countries in Europe made, learn from our mistakes. I mean, the most important thing that we're still not getting right is testing patients. We still haven't got a testing facility going. We had this app which failed, and we still haven't got it right. We still don't test enough. The tracing is still not working out for us either. You know, we're still, I hate to say this, but I think our government was at 2 months behind the curve, and you now have the facilities to look at where the mistakes that we made to try and not make the same mistakes.
Right. If I may perhaps go to the next question from Anne Reynolds. Very open and honest, thank you. Following on from the comments about involving medical professionals in dealing with this pandemic, I would love to hear your comments on what was the role of the allied medical professionals, such as OTs in particular.
Shall I take that? They were fantastic. The physiotherapists and occupational therapists and all the allied professionals were amazing. We used to have proning teams on our intensive care unit whereby that was run by the physiotherapist. So the physiotherapist was in charge of the proning, and I was just a pair of hands sometimes, just turning the patient over, making sure the patient was fine. We had OTs on the ward, on the COVID wards, that were you know, helping poor patients that were on CPAP and nasal oxygens and oxygen therapies and so on. The allied medical teams were, I would say, it wouldn't never have worked without them. They were absolutely fantastic.
Thanks, Prof. Another question here from Isel Smuts. Apart from the COVID-related stress, doctors have additional fear of the medico-legal ghost. All of us fear that something may go wrong and lead to some form of blaming in this very difficult circumstance. Is there any way that we can minimize the additional fear?
Shall I take it?
Yes,
we had 100, and so far we've had 121 deaths of medical workers in our. Never mind the thousands that have been very poorly with this problem. There's always a worry about medico-legal aspects associated with this, but I think the most important thing is to be a team, is to not take it on your shoulders and discuss. So if you have somebody you're not quite sure about, discuss it with a team. Teams are the most important, you know, and if there's a leader of the team, discuss it with them. I think medico-legal issues always arise because communication is lacking. And, you know, if you're not sure about turning up the FiO2 on the ventilator, if you're not sure about, is that patient really, you know, pulse oximetry, is that patient, do I need to talk to somebody about that? Do I need to, you know, the answer is, if you're worried about something, then communicate. The big problem in medico-legal things is if you do know and you don't communicate, you will then get into trouble. So if you know something, communicate it. Even if it doesn't matter. Most of our medico-legal and problems are such that we either know about it and haven't done anything about it, or we've done something very, very stupid. But if you're not sure about doing something, always communicate. And none of us have got into any problems with this COVID crisis because we've worked as huge teams and everybody's been speaking to each other, big meetings in the mornings, everybody knows what's going on. Just don't take it on your own shoulders.
Yeah, thanks for that, Prof. And also, you know, the test for negligence is with the reasonable doctor and the circumstances. And I think that's going to become a very important question that the lawyers, the insurers, etc., are going to have to really look into, is the circumstances that you guys are all needing to operate in. The one thing that perhaps we will discuss in due course in the seminar or the webinar in August, or the lawyers and insurers will get together. One thing that was brought up was the marginalizing of non-COVID conditions. I do know, spoke to a surgeon the other day, and he said, you know, he's begging his hospital just to leave one ventilator open for the other patients that you know, that are non-COVID patients, but that need that, or that need surgery. So that's quite something that we're going to have to look at in due course. Another just a question from Gail Wachkansky. Is it possible to tell us a bit more about the focusing technique used to treat PTSD? Jonathan, is there any chance you can answer this one?
I can. So I may have given the wrong impression. It's more, I think, a psychological first aid technique. And I asked my friend Dr. Jane Stevens yesterday if it was okay for me to give her contact details, so I'll send them to you. But it may well be that can use it to treat PTSD. I don't know, but it's certainly more a psychological first aid technique that you can literally, once you know how to do it, you can just, you know, grab the person you think is suffering and literally very quickly try and offer a bit of help that can be very invaluable in getting through. But yes, if I send you all those, but also I mean, there are, I'm sure you've got them in South Africa, but there's Red Cross, WHO guide, and a lot of these are guidelines on how to set up some kind of course that you can give as training. And something that I didn't mention was that often if you present it as training rather than a service you can go to, you get a lot better take up, because it's just a training. So let's go along, great. But if it's you know, or you go down that corridor, the last door on the left, that's the psychiatrist's office, you know, that people just don't do it. They just don't. So yeah, but I'll send all of that to you, Romany, and people, if that's okay, you can just... That
would be fantastic. Yes, thank you so much. Yeah, there are various, I mean, SASA, I was speaking to Natalie Zimmelman from the South African Association or Society of Anesthesiologists, and they have an incredible amount of information on triaging, on all of this, and how to sort of, for doctors, as you say, psychological first aid. And they have an app, and if you look on the App Store under SASA, SASA, it's an absolutely incredible app, which I've been going through today, and I think will be of great assistance to all the doctors and nurses. And, you know, just seeing from a couple of comments that, you know, I see there are obviously lots of OTs and psychologists here in the audience, and they've said, you know, call on us, please, how can we help? And so, you know, there are various mechanisms. I know Discovery Health, which is one of our health insurers here in South Africa, they are, you know, helping the medical practitioners and specifically the medical students that have been called up as well. And we need to, what I'll also look into is putting all that information out there so that all the therapists can offer up their services for the doctors. I see we are coming towards the end of time. I just want to, there's a couple of comments. There's one comment here: in a war zone, the soldier is better prepared with purpose and self-motivation. With COVID, we're in a terrorist zone, the enemy is hidden, the end is not in sight. This leads to chronic low-grade stress. And that's from Dr. Casson. And yeah, you know, I still need to pinch myself. It hasn't sunk in, and you know, I'm still trying to process February and March, and we're going into July. So it's incredible times for all of us, and I just want to thank you once again for your time, for giving of your time and your experience and knowledge and sharing it with us. And I just think it's, you know, it's so important to do this. And as you said, it's a leveler. This has been a leveler for everyone, and to bring us all sort of onto the same level and learn from each other. And as you say, teamwork is the way to get through this. I want to thank Genoa for assisting us with this platform. They've provided this platform. They're also going to be assisting with the CME or CPD points. The doctors will be getting their 1 point for 1 hour. And they also helped out with that poll, the mental health poll. So thank you very much to them. And I want to also thank my team, Elise and the whole team from SAMLA, the South African Medico Legal Association. And as I said, we're going to continue the conversation in 2 weeks' time on the 16th. We are going to be offering a little bit more information and solutions with regards to the mental health and mental strain. And then in the beginning of August, Norton Rose Fulbright, the firm that I work for, we are going to be looking and advising the doctors, insurers, and anyone who's interested on legal liability and what we are going to be faced with, or what we can, actually just, we don't know what we're going to be faced with, but let's throw around information, ideas, and solutions. And thank you again for all the speakers and all the delegates who joined. Really, really appreciate it. And until we meet again.